have two guests today. Dr. Joe Thompson. Dr. Joe Thompson's received a couple of awards here recently. One is the Person of the Year from the Municipal League. And then if you notice in the Arkansas Money and Politics, they named about 20 influencers, and he's named as one of the influencers, if you will. Pretty elite group of people. And we thank the world of Dr. Joe. Before we go to his update on COVID and the world of COVID, as you all know, we think he does as good as anybody anywhere. Stuart Nance and I were talking about this yesterday about how well he handicaps all the information and brings us and educates us. And we're so grateful that he takes the time. He and I processed, were we okay to continue to go forward? We feel like we should go forward a little more, months in the future. And he felt like there's enough there that yes, that he'd love to be able to do that. He seemed to enjoy it. We didn't want to overstay our welcome. As you know, he does this for the Municipal League and the State Chamber of Commerce as well. And he's a very busy man, setting, the health policies of the state through the ACHI and his 40-person team that brings us some of this content. But before we do that, I wanted to ask Diane to cover some items of the future event coming up. So Ms. Diane, my associate.
In addition to having our monthly open forums on the second Tuesday of the month, we also are doing our Pillar series that will be held the third Tuesday at 10:30. Coming up next week, we have our third part for technology for CEOs we partner with the Adafio to cover, this will be emerging trends in the technology field and, your partnerships and when to decide who you will, when to outsource. And we hope you can be there, or if you have other associates in your firms that you would like to join, or other peers, we welcome guests to join us every Tuesday for our open and for our Pillar workshop. It'll be every month. Mark your calendars, and we hope to see you there. And just a quick mention, we still have our Accelerate 11. We'll be starting soon, so if you have anyone for that, let us know.
It's a great way to demonstrate how you value your people by putting them in the Accelerate Leadership Program. We're looking for those that are A players that you want to further invest in so they can take on more responsibility sooner. So thank you, Diane. And Keith is on the call with us. The Adafio is a 100-person IT firm based in Little Rock, but also here in Northwest Arkansas that are subject matter experts around technology. So they're going to get into also common mistakes that CEOs make so we can not make them. So we'll get into some of that good stuff. That'll be good. So thank you for that. And our two guests are Dr. Joe Thompson. And then after that, Scott Hancock, a great banker that runs, he's the division president of the Centennial Bank here in Northwest Arkansas, and just a really good banker. We think the world of him, really involved in the Fayetteville Chamber and other things. So we'll get to hear from Scott as soon as Joe and the questions. We'll have a question and answer at the end of Joe's presentation. So the best we found, Dr. Joe Thompson, please take it away.
Well, thank you, Tim, and thanks for the trust and the opportunity. I'll be with you. We're not through the woods yet, and we got a ways to go here, but we are making some progress that I'm excited to share today. Let me jump in here. I think, let's see. Can you see that now, the screen?
We can, yes, sir.
Right, let me jump in here. And I'm going to go pretty fast. Y'all interrupt me with any questions along the way. We're comfortable with each other, so you're not going to ruffle my feathers too much. You may throw me a curveball with a question, but I'll be glad to take that, and we'll see what we can do with it. Well, I'll say that. How do I get to? Here we go. We continue to lead the world on number of cases and number of deaths. This is not new. Unfortunately, I think, we are seeing the continued negative impact of some of the divisiveness and some of the misinformation that we've had, although I'm hopeful that some of that we can eliminate going forward. We've got about 10% of our Arkansas residents now, over 300,000, that have been documented to have had COVID-19. It's probably 2 to 3 times that in its entirety is a best guess I can give you. We're down from our peak where we were having about 25,000 active cases. We now got about 15,000 active cases today in the state. You see the number of hospitalizations now less than 1,000. That's good. Our ventilators continue to creep along, and unfortunately our deaths continue to accrue. The trauma regions we have converted to hospital regions. The governor and Secretary Romero have kind of adopted the use of these regions, but because they've added COVID to the COVID comm to the trauma comm, they're now calling them a hospital region. So we're all in one place now. And the numbers there, you know, we broached 10 per 1,000, which would be about 1% 6 weeks ago. And now we are trending downward in most of our regions. I think what we don't know, and I think this is what we still have outstanding, you see kind of 3 humps here. You see the Halloween effect, you see the Thanksgiving effect, and you see the Christmas effect. And those compounded on top of each other so that we had that peak around the first half of January, and we've come down significantly since then over the last 4 weeks, which is good. Ideally, you would see that continue to come down. What I'm afraid we're probably going to see is we're going to get back down to a baseline, you know, burden that stays flat for a while. But this is, you know, evidence of us doing what we know need work. It's not number of vaccines and it's not monoclonal antibody. This is reduced transmission because of some of the defensive efforts that we have underway. We've added some new regional reports that are on our website, updated every Thursday. It takes a lot of the numbers that we have and we'll break it down by region to allow, you know, more local tracking of progress as we go forward. I think we've had some positive responses from that. We continue to do our zip code new infections for the last 14 days. This is a little lighter than it was the last time we were together. You'll see the top zip codes there. You know, if you have 468 per 10,000 residents, that's a 4% positivity rate for everybody that lives in that zip code. So we do still have hot spots, but you see a few of the lighter colors here starting to emerge. We are seeing the same improvements in our hospitalizations. These are, you know, the drop off over the last 4 to 6 weeks in the number of those that are currently hospitalized. I think this is good news and has taken some head pressure off of our healthcare system. We unfortunately do still continue to rank a pretty high number of deaths, although that is starting to come down too. This is again a positive response. I think we had the 3 waves there of Halloween, Thanksgiving, and Christmas, January, New Year's that compounded on each other. And now that we've kind of gone back into a relatively defensive position, it's cold, we're not coming together. I hope we didn't have another spike over the weekend with the Super Bowl events, but we will continue to track that. You know, our deaths, again, the 100 deaths, we're up to 5,100 now, which is an unfortunate burden on our families and our state. The hospitalizations continue to rack up, and we're having younger folks be hospitalized here. You'll see the largest number now in the 45 to 64-year-old age range, but we've had over 2,000 in the 25 to 44, and we're even seeing some of our younger kids have hospitalizations due to the illness themselves. No real new news on treatment options. We still have the monoclonal antibodies that are increasingly available. I think I asked last week at the health department how many patients have been treated with monoclonal antibodies. I think the number statewide there is somewhere between 5,000 and 6,000. So again, an important effort to try to keep people out of the hospital, but not at scale for all of the individuals that are infected. We still have the efforts inside of the hospital if you are hospitalized, but again, no new knockout drug here, either available or on the horizon from my perspective. In our schools, you know, this is increasingly a national dialogue. We are seeing a lightening here. We have some green school districts again, which we have not had for a long time. Still have some hot spots there in the purple areas with more than 1% of the residents in those school districts actively infected or newly infected in the last 14 days. So some progress there. These are the school districts, the residents that have the highest rates, and this correlates with those purple counties. Unfortunately, the health department also reports active infections inside of school districts. These are students and personnel. And you up in the northwestern part continue to rank 1, 2, and 3. You've been the top 3 now for 2 months, with Bentonville, Rogers, and Springdale moving positions, but y'all have had the most active infections in the schools themselves over the last couple of months going forward. Little Rock and Conway are consistently up there also. So these are active cases inside of the schools themselves. We do know that you can, and this is some of the national dialogue in some of the larger cities, they've studied that if you use masks, if you keep students grouped in smaller groups, if you try to maintain that 6 feet of distance, and if you do contact tracing and quarantining appropriately, we can have in-person school. This is a study the CDC published from Wisconsin, I believe, where, you know, during 13 weeks of in-person learning, out of 4,800 students and 700 staff, almost 700 staff, they only had 7 known infections, and that includes exposure outside as well as inside the school system. So this is, you can do it. It just takes commitment and it takes diligence to actually maintain the safety of those internal protections, and also the adherence when kids go home and in the community itself. We've got good news on the vaccine update. I think this is where we're able to go on offense some moving forward. This is the New York Times vaccine tracker. As with any developing, you know, science, you do have failures here. And so we've got several vaccines over on the right-hand side that have been abandoned because they were not shown to be effective. And we've got 4 that have been approved worldwide for full use, and 6 that are in some of the latter stages of trials. In our state, the state in the middle part here, the state doses that have been received, we've received over 560,000. Almost 380,000 of those have been given. So about 2/3 have been deployed. This is important because if we go back to say, okay, we know 300,000 folks have been infected and tested positive. Let's say there's another 300,000 that may have been infected and never been tested. That's 600,000. We've got vaccines deployed for another 300,000. So we're looking at 1 million people now that have been either exposed or infected, either infected or vaccinated. And so we're starting to get some of that breaking power, if you will, in the communities. We just have to keep doing what we're doing. The CVS Walgreens response over on the right, you know, that is one of those federal programs that may have been a good idea at one point, but it just didn't materialize. I think you've got a new retail pharmacy strategy that has included Walmart in its distribution efforts, and many of the rural states, Arkansas included, are choosing to use Walmart because of its proximity to, you know, rurally placed citizens, as opposed to CVS and Walgreens, which are in some of the larger cities and communities. The questions about our vaccines, safety, almost all of our vaccines that are deployed have very high safety profiles, have very high effectiveness profiles. We don't know about duration, how long the immunity is going to last, although it's promising. There are some issues around how easily is it able to be distributed, and we'll touch on that. And then the wild card now is the level of threat from the new variants that are emerging worldwide because of mutations of the virus and its ability to escape our offensive strategies. Here are the 5 leading vaccine candidates. I've got a handful of slides here to go through these. Pfizer and Moderna are the 2 that are out, and they use that messenger RNA strategy, which is, you know, basically a piece of the genetic code that forms the spike protein that then lets our body know what to watch for. The Johnson & Johnson vaccine actually uses an adenovirus, a live virus vector, which does not cause illness itself, but it carries some of the profile of the COVID-19 virus in that your immune system then gets exposed to. Astrazeneca also uses a viral vector, and then the Novovax, which is in the pipeline, is a protein component of the cell wall of the vector. The dosing is similar for most. Most require 2 doses, either 3 or 4 weeks apart. The benefit of the Johnson & Johnson vaccine is it is a single dose. With one dose, you actually have, you know, a low grade infection because of that adenovirus, and therefore you only need a single dose with the Johnson & Johnson vaccine. With respect to effectiveness, Pfizer and Moderna have very high levels, 95% plus. Johnson & Johnson is a little less on symptom in that the Johnson & Johnson vaccine, more people had mild illness than Pfizer and Moderna. Importantly, in all three of these, Pfizer, Moderna, Johnson & Johnson, of all the clinical trials, not a single individual died who got any of the three vaccines. So while the Johnson & Johnson numbers don't look as good, the actual protection is equally good in terms of severe disease and avoiding kind of the long-term or the more severe outcomes. Astrazeneca and Novovax are in the pipeline, not yet submitted. We'll get to where they are. There are some storage issues. The Pfizer vaccine, you know, has to be stored almost at minus 100 degrees Fahrenheit. So it really has some restricted, and it comes in 900 and I think it is 75 dose units. Moderna has some pretty significant refrigeration, but it can be stored at a regular temperature for a longer period of time. There you see the 30 days at a regular kind of freezer. And then Johnson & Johnson can be 90 days at a regular freezer. So again, some of the storage issues affect distribution. We have Pfizer and Moderna that are in emergency use authorization. Johnson & Johnson has applied for that. I think they will likely get that maybe by the end of this month. And then AstraZeneca and Novovax are in phase 3 studies under review with emergency use in the United Kingdom for AstraZeneca. The side effects are pretty mild. What I'm hearing is that they are more significant with the second dose than the first dose, but that makes sense because your body's been didn't know what it was seeing on the first dose. And when you get the second dose, if your immune system revs up a little bit and you have some mild fever or some soreness or, you know, some fatigue for a day, that means your immune system is getting, you know, the profile of what to watch for. Number of severe incidents is very low. They are tracking these. That's why in the previous slide, the phase 3 trials continue to watch for any longer term adverse reactions. You know, we completed phase 1A with healthcare workers, first responders, our nursing home residents. That was about 230,000 folks. We're in 1B early phases now with Arkansans 70 and older and our educators. You know, if you have about 330,000 individuals 70 and older and 132,000 in K through 12 and higher ed. Obviously, if you add the 300,000 on the previous slide, the 300,000 plus 132,000, we have more folks that we're trying to vaccinate than we have vaccines for. So this is a restricted kind of phased approach to try to help get those that have most risk or most exposure vaccinated first. When we go to the second part of phase 1B, it will, you know, continue to expand that number of individuals. This will be, you know, fire and police, our food and agriculture workers, manufacturers, public transit. You know, this is trying to help us be able to get back to normal as safely as we can, as quickly as we can. And then 1C, probably by April, we're looking at lowering the age range and then bringing in younger individuals that have medical conditions at risk. You'll see the numbers here on essential workers. You know, the vaccine pipeline is our restriction right now. And as we get more vaccines approved and as the manufacturing scales up on those that have been approved, you know, I anticipate that by May or June, most Arkansans will be able to avail themselves of a vaccine if they want to. We are also seeing more acceptance of the vaccine after it's been out. There was a fairly high level of, I'll take a pass on the first time through with the healthcare workers. But by the time the second dose came around, more healthcare workers were adopting it. And now, you know, that 1A door is about to close. The healthcare workers will have had their turn and the vaccine will be going to those that are in 1B and ultimately those that are in 1C. Let's see. This is a distribution priority, and this goes back to the freezing requirements. The green counties are who got the Pfizer vaccine because it required such a severe low temperature. So those cities, communities with larger hospitals that had the freezer capabilities, Central Arkansas, Northwest Arkansas, Jonesboro, Northeast, they got the Pfizer vaccine. The other counties were prioritized for the Moderna vaccine, a more rural part. So that's why you may have, if you got loved ones that got Moderna versus Pfizer, this is probably the reason, is where they lived and who was managing the process more than anything else. You know, we are keeping up with the nation, actually maybe moving out a little bit with about 13% of our population now vaccinated. That's a good thing. And again, it's the pipeline that is our restriction right now. Some new things that are coming out. I think the CDC is likely to require individuals, has required individuals from other countries to have a negative COVID-19 test within 3 days of travel. I think this will continue to advance. The restrictions probably going to grow. The Biden administration is restricting all travel from South Africa because of the variant there. So I think this international travel and possibly even domestic travel will require evidence of a negative test prior to boarding an airline to try to decrease the transmission here in 2021. Questions about employers being able to require the vaccination. This is going to be a interesting issue going forward. I think generally the rule is yes, that employers can make it a condition of employment to have the vaccine. There are obviously some exceptions if an individual has a medical objection or other things. I think probably those requirements will wait until there's full FDA approval, not while it's under emergency use authorization. But I can also see a public's demand for publicly available information. If I'm going to put my loved one in a nursing home, if I'm going to go to a hospital, if I'm going to go send my child to school, to know what the level of vaccination and protection is in the workforce that I'm going to subject either myself or my loved ones to. So I think this is something to stay tuned to. This is a tricky virus, as I have always said, and we are seeing some of the mutations now. This is, there is a genetic profile of this virus, and every time it replicates and jumps to the next person, it has the potential to have mutations that it carries with it. And with those mutations, the ability to escape, if you will, the strategies that we've been developed. There are 3 variants of concern. There's the UK or Britain variant, there's the South African variant, there's the Brazil variant. They all appear to spread more easily. The UK variant is the one that we know about. It potentially spreads 50% more effectively. That ultimately leads, the more spread you have, the more cases you have, the more hospitalizations, more deaths. So at least the UK variant is a much more infectious entity. So far, with the exception of the South African variant, the antibodies generated through our vaccine appear to recognize these variants. There is some concern about the Astrazeneca vaccine not recognizing the South African variant, and we're watching that going forward. These variants are here. The UK variant is in all of these states, with the hash states having more than 100 cases. The Brazilian variant is in Minnesota and Oklahoma. The South African variant is in Maryland and North Carolina. So these variants are within the United States now, and I think are a significant cause for concern, and another kind of call for us to redouble our defensive efforts of masking, distance, and hygiene while we have our offensive efforts of the vaccines moving out. It's kind of a cartoon of the reason that they are so much more infectious is they adhere to us much more aggressively. So it's kind of the difference between Scotch tape or duct tape. The new variants have duct tape on them, and when they attach those spikes, it's like a much more solid and effective attachment point, which then makes them more infectious going forward. What we don't know and what we're going to need to monitor is how wide is the spread of the variants. Is the disease different in these variants and how they attack us? How do they affect existing therapies, including our vaccines and the testing strategies that we have? There are studies underway here, and South Africa, as I mentioned, paused their Astrazeneca vaccine because it appeared not to be as effective against the new variant discovered there. Just to close out, we are in our legislative sessions. There are a number of issues that are, I think, a cause for concern on the health front. Specific to COVID-19, there are now 5 bills, and I'm aware of another bill that is coming that would either immediately terminate the Public Health Emergency Authority or curtail the executive branch's ability to have emergency health authority. So these, I think, are a reaction to what we've all experienced in the last 12 months. But I think my board's position, which will come out publicly, is that the governor and his team need to have public health emergency authority to be able to execute nimbly and to continue to provide protections and not be subject to what some of the legislators want, which is a special session of the legislature or the lack of ability to impose fines or directives or restrictions. There are a couple of other bills that came up, and Tim, I'm going to do a little bit of a soapbox here on one of your calls. In the last month or so, there were discussions about the ranking of Northwest Arkansas and Arkansas generally on our our desirability index. We were 92nd in desirability, I think it was, or you were in Northwest Arkansas. There's a bill that passed out of the Senate Public Health Committee yesterday that would allow physicians, this is Senate Bill 259, physicians to, if they had a conscientious objection to providing a service, they would not have to either inform the patient of the service or provide the service or refer them to the service. So, this is targeting individuals in their reproductive interests, also individuals in their gender interests. This is just another, I think, a move in the wrong direction for our state in terms of being an attractive place for families and for businesses to relocate. It's kind of ironic to me that we're going to allow physicians not to provide services, but we can't get a hate crime bill out. So if you think about a major company trying to attract talent that happens to either have a gender identity or a homosexuality issue, their physician wouldn't have to treat them, and they wouldn't necessarily be protected from hate crimes against them. And so this just, again, I think is a situation that I would want to call your attention to. We've got our updates. I think that's it. I'd be glad to take questions. Look forward to being with you as we are successful against the virus and the new tricks it tries to pull on us with the variants that are emerging from around the world.
Thank you, Dr. Joe. As usual, very good update. I want to just mention what Dr. Joe was talking about. Mike Malone was kind enough to come on with the Runway Group, and part of the strategy for the council, Northwest Arkansas Council and the Runway Group, is to see if we can reach #1 best place to live and work, and through U.S. News and World Report, which everybody thinks is the best report out there. And we score very well in everything except the desirability. It's a kind of a statewide issue that we get caught up in that drags us down. So that's what he's talking about. And a lot of the desirability has to do with no one knows about us. So a lot of it's just the branding issue of who we are. We're not a city. We're not a greater Austin, or we're Northwest Arkansas. So that kind of makes us a little more benign, if you will. So it's not as bad as it sounds, but it is the one that hurts us from getting to #1. We're #8 now. We got up to #4 in the most recent one. We were #8, which is a dang good, very good, and we score in a lot of good areas. So that's a little background there. So now I'll open it up for questions for Dr. Joe.
I've got one, Tim.
Yes, sir, Jay.
Hey, Dr. Thompson. Very informative as always. My question is about these new variants that just scare the heck out of me, like the South African and the Brazilian variants. I heard on the news that even wearing two masks, that this thing can still slip through the air pockets to infect people. Is that true? And if so, are N95 masks going to be made more available, or are those still kind of in short supply and only available for first responders?
So great questions. Let me. You got 2 or 3 in here. Let me tackle them. There's no question that as this virus mutates, it is a real risk that it appears that it is much more infectious. All of them appear to be much more infectious. The UK in particular, is 50% more infectious. What that means is any exposure then becomes more likely to lead to infection if you don't have the protections. The other thing it means is as they mutate, they have the potential to escape the controls that we hope to get from the vaccine. So far, except for the South African variant, it appears the Brazilian and the UK variant, it hasn't changed the spike protein that much, so that the vaccines still appear, all the vaccines still appear to be effective. The South African variant, the Astrazeneca vaccine, is one of the few that actually was tested in South Africa, so we have knowledge about that vaccine. We don't really know about the Pfizer and Moderna vaccine yet. So I think they're more infectious. As they mutate, they're more able to escape the strategies that we put together. Now let's go to the masking. I got to ask this. I mean, it's clear that we know that all of these are spread by, respiratory transmission. So the barrier of a good fitting mask is important. I don't think there's any science that says that 2 masks are better than 1, but I don't know that you need science to have logic that 2 masks are better than 1. I mean, if it's a barrier protection, then if you have 2 barriers, it's better than having 1 barrier. So I think it's logic, not science there that I would appeal to. With respect to the N95 mask, I think you are going to see a resurgence of whether it's N95 masks or whether it is maybe a new, more commercially available, better functioning mask. The N95 masks are medical grade masks that are frequently used in the healthcare setting. I wouldn't be surprised if you end up with a commercially available mask that is specifically designed, to be more comfortably fitting, but of a higher level of protection than just the average surgical mask or some of the other masks that folks are using now.
Okay, great question. And Dr. Joe, I heard you say that the vaccine, how long it might last. I heard you say things look good in that regard, even though we don't know.
Well, this is a new infection, and these are new vaccines. So we're going to have to see how long the protection lasts. There's no way you can rush that in a trial to say, okay, well, is this going to last 1 year or 2 years or 3 years? It appears so far that folks are mounting an antibody response and that it is lasting, particularly against the protections are lasting, the antibodies are lasting in individuals that have been vaccinated, and that those antibodies, those high levels of effectiveness are working. It's if the variants come up with a new trick that the antibodies that we create with the vaccines don't recognize that new profile. We go back to, the vaccine kind of gives the FBI profile of the most wanted. Well, if the most wanted has a facelift or does their hair differently, then it may not be recognizable. And that's what I think the variants are, the threat in the future.
That's very well put. Okay, thank you. Other questions? This group known for great questions. I think you've done it so well, Dr. Joe, they don't have many. One last chance. Anybody? Jody?
I'll ask a question, yes. So unfortunately, our family was hit with COVID, but fortunately we did fairly well through it all. And I'm quite a ways away from being eligible for a vaccine. But if say my mom had gotten it, which she did not, would she need to delay her vaccine because she's had it? My dad received the BAM infusion. So they said, wait 3 months before his vaccination because he had that monoclonal antibody. But if somebody was just infected and recovered, should they get the vaccine when they're, should they wait to get the vaccine?
Great question. You know, if you have had COVID and you have recovered, you have built antibodies to the COVID with your own natural reaction to the infection itself. You'll remember that, you know, a number of people, maybe 40 to 50% of people, don't have any symptoms when they get infected. And so they don't have, I mean, if you're not having symptoms, your immune system has successfully defeated the virus in the short term, but may not have mounted a response to give you long-term immunity. So the recommendation by the CDC is that everyone, even if you've had COVID recently, take the vaccine when offered. Now we're in a restricted, you know, situation where we don't have as many vaccines as we have people who want them. So, you know, if you're in a family situation and you've got 2 people and only 1 vaccine, I'd get the vaccine for the more at-risk person. But I think the strong recommendation is even for people who've had COVID-19 to take the vaccine when offered. It functions basically as a booster dose from the infection you already had. Now, a sidebar, just to reemphasize what you correctly stated, if you are sick and if you got an injection of the monoclonal antibody, you need to wait at least 3 months for your body to clear that antibody, because if you take the vaccine, the antibody that you got injected with is going to attack the vaccine and you're not going to get your immune system to respond to it. So that's why if you got the antibody injection, you got to let your body clear that antibody for 3 months before the vaccine will be effective when you take it.
Thank you so much. I appreciate you.
Glad everything worked out well with your family.
Me too.
Yes. And Jody, I'm going to ask you to mention an event y'all coming up here in just a second after the questions. If we don't have any more questions, if you're okay to do that with your leader relating to your organization. Any other questions? Dr. Joe, well done.
Thank you for the opportunity. I'll be with you next month.
We need to just move you on up the ladder, let you run this place, run this country, this state if you want to, you know, in our mind. Jody, before we go to Scott, why don't you just mention something that I thought what you are getting ready to do is very exciting and says a lot about your organization. Share with them a little about, some people may not know who you represent, so if you don't mind.
Sure. I'm Jody. I'm with Arkansas Community Foundation. We have a Northwest Arkansas satellite office, although our headquarters is in Little Rock. And typically each year we gather people who are generous and concerned about our state, and we provide information that helps to inform where there are needs in our state and how you can get involved and make a difference. Our tagline is smart giving to improve communities. So we're calling this the Smart Giving Social. Obviously it's happening online in a virtual setting. We can't gather in anyone's home or outdoors socially distanced. So we'll do this online via Zoom. It'll be a happy hour style format. And this will be just focused on Northwest Arkansas, and we'll be discussing the importance of quality early childhood education, what that means for the developing brain, as well as what that means for future workforces when you have employees who can operate well with using executive function. All of that develops in early childhood. So we have 3 experts who will be sharing information very briefly to sort of whet your appetite to learn more about quality early childhood education. And if you're interested, please reach out to me through Tim, or I'll put my contact information in the chat room and I'll send you the Zoom link. It will be February 24th at 5 p.m.
Great. That really looked appetizing and just says a lot about your organization. Everything that comes out of your organization is top notch. So we appreciate all you do for this region and state.